That's what metastatic breast cancer looks like now. Patients can live an extended period of time. And sometimes I think we forget to cheer for stable disease. I tell patients they can live with weeds in their garden. They just can't let the weeds take over their garden. We live in a rapidly changing time in oncology. There's just so much hope right now that we can offer patients.
You're listening to the ONS Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Kristi Orbaugh, nurse practitioner at Community Hospital North Cancer Center in Indianapolis, Indiana, about challenging conversations about metastatic breast cancer. This podcast episode was developed by ONS through a sponsorship from Lilly. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Welcome. Thanks so much for joining us today, Kristi.
Thanks for having me, Jaime. It's good to be here.
So we know a diagnosis of metastatic breast cancer, or any cancer for that matter, can be devastating to patients and their loved ones, their family. And so we know as healthcare professionals, we need to approach these conversations about diagnosis, prognosis, and planning with sensitivity, intention, and with care. Can you help describe some of the methods that you have used to have these difficult conversations? And are there any tools or methods that you use as part of these discussions?
There's certainly some very, very good tools that help shape those conversations. Before I talk about the tools, though, I think the most important and vital piece of having those conversations is making sure that we really know that patient. Because if we know them, that helps guide what they're needing, right? Then helps guide our verbiage, helps guide disciplines that we bring in. So certainly we think about using the spikes protocol. That's a real common one. Also, the breaks protocol is another very common one. I think we all learned those in nursing school. Spikes is kind of an acronym, thinking first about the setting, right? You don't want to have a very difficult conversation in the midst of a busy waiting room or in the midst of a busy hallway. We really need to make sure that we're intentional about being very present with that patient, making it a quiet, calm environment as much as we can, understanding what the patient perceives of where we are right now and understanding their needs, right? I may have an agenda that I think I need to discuss with them, but if that's not the agenda and the needs of the patient, they're really not going to be able to hear what I'm saying to them at that time. So really important that we understand what they're coming to the table with and what their most important needs are right then. And then what do they want to hear? Kind of an invitation, right? What do they want to hear? I've been in practice a really, really long time, and I've had the entire spectrum, Jaime. I've had patients say, tell me every single detail. I mean, they want pictures, they want graphs, they want me to draw things. I've even had patients that want me to take markers and mark their body parts, That's only been one or two of those. And then I've had patients that say, I don't want to know anything. I don't want to know anything. I trust my healthcare team. I'm going to proceed with treatment, but I really don't want to know anything, which is important. And then understanding their knowledge. I'll never forget this patient, such a precious patient. And we were having one of these very, very difficult conversations. I kept talking about how her disease was progressing. I thought I'd explained everything well. I got to the end of what I needed to say. And she said, but what disease do I have? I was using the word disease as cancer or her malignancy. That's not what she was calling it. I was using the wrong verbiage. And I wish I would have picked up on that sooner in that conversation. And, making sure we understand the emotions. We're potentially walking into that room and rocking their world. Things might have seemed pretty settled in their life, and we're walking into the room and offering them new information that, not to sound dramatic, Jaime, but really change from that moment forward how they're looking at life and the decisions they want to make. And then probably the most important thing I try to remember too, and I'm sure you do, is try to put yourself in their place and be as empathetic and as caring and as compassionate as we possibly can be.
Absolutely. And I think you starting out sharing how important it is to know your patient. Sometimes we have to have these hard conversations the first time we meet them. And that makes it even harder because, of course, over time, you do want to get to know this patient and be able to address things in a way that meets their needs and matches their values and their priorities. But sometimes the first conversation is the hardest. And so being able to blend that and sensitively get to know them as you have this conversation, blending that together in one single discussion is really important to be able to try to pull on those threads as early as possible and understand, as you mentioned, what do you want to know or what do you already know? What do you come to that first conversation and that discussion with? How many stories have we heard of patients being referred to their oncologist by, their primary doctor or another specialist, and they don't even know what they're being referred for. And just how hard that conversation is. You think that they know, they know they have cancer, they're being sent to an oncologist, but sometimes that message is not delivered. So that can be an important thing to, as an upfront, establish what knowledge do you bring to this conversation? What do you already know about your cancer, your diagnosis? And as you said, terminology, making sure that you are clear in the word that you're using, especially upfront, trying to establish that baseline knowledge.
One thing that the oncologists that I work most closely with always ask a new patient, not that it's this earth-shattering statement, but he always starts with, what brings you here today? I think that's a nice opening because, some people will know right away, well, I've got this tumor and they say it's cancer. And some people are, to your point, Jaime, I don't know. My primary care told me I needed to come and see a doctor like you. That's a good opening. Studies will indicate patients want you to develop a rapport as quickly as possible, but it is kind of hard to come in with a brand new patient with this bombshell, if you will, of information and try to have rapport, that intimate rapport that we develop with patients over time. I don't want to sound flippant at all, but you can't necessarily walk into a room and say, okay, tell me, how many kids do you have and what's your husband's like? And do you have a dog? And by the way, you have cancer.
Right. It's not an interview. It has to be more organic than that.
I don't mean that with any disrespect. The rapport is important, but when they're walking in for the first time, sometimes it's a little hard.
In your experience, how have you seen different ways that patients prefer to receive their information if they are diagnosed with metastatic breast cancer? Are there any different ways that you can share of how people have wanted that information provided? And is there any research that sort of supports different techniques?
Studies have shown that patients respond best to direct and emotionally honest communication, even if it's very, very difficult news. I'm finding more and more patients want to see their scans, which kind of surprises me and makes me want to go back and meet with radiologists and review all that. We don't really learn a lot of that in nursing school, do we? But patients want to know, or Google Images is very helpful sometimes to pull things up. I actually just saw a patient yesterday. It's a man. I realize we're talking about metastatic breast cancer, but it's a gentleman and he has an adrenal met and he's having really bad left flank pain. And most likely it's from this metastatic deposit in his adrenal. And he's like, what is my adrenal and where is it? We don't grow up talking about our adrenal glands very often. And he's a real bright guy, but he's like, where is it? So being able to show him images, I think, are somewhat helpful.
I think it's interesting as I'm just listening and kind of thinking back on my own experiences. as working in oncology for many years, I don't want to say we become hardened to it, but it becomes routine. It'd be like just, here's the diagnosis, here's what comes next, here's the treatment. Like that's what makes us as oncology nurses very skilled at what we do, because we know what sort of the routine is. We can anticipate what needs to happen. And from just a process and a logistics standpoint, like we kind of can see the pathway. But as you originally mentioned, that empathy of recognizing that every patient that goes through this is hopefully their first time going through that. And so, like you just said, we can't assume, even though it's second nature to us, whether it's the terminology, the anatomy, the process, what happens next in the treatment plan. Those are all routine for us as we've become very experienced in this specialty. But for every patient we encounter, it's hopefully their first time. And maybe it's not. Maybe they've gone through it before themselves or with family members, but we can't make assumptions on what they know or what they understand. And so it falls on us as the clinicians to invite them to ask those questions or to encourage them to not be afraid to ask anything or ask for clarification, even if it's something as simple as, well, what's an adrenal gland or where is that? That's part of our role as well.
And understanding the verbiage, right? You and I as oncology nurses, we're going to talk about neutropenia and we're going to talk about peripheral neuropathy and we're going to talk about these things that we talk about every single day. Those are big words. Those are like very common to us because that's our wheelhouse. I had a really good personal lesson to that recently. We've had to work with a plumber. We've got some plumbing issues at my home. And the plumber comes in, and I like to think on most days, I'm fairly intelligent, right? And he's telling me what needs to be done and what the problem is. And Jaime, he might as well have been speaking a foreign language to me. And he was talking about my plumbing. And I had to say, I don't understand what you're saying to me. And he was just using words that are very common in his wheelhouse. So I think remembering making things as simple as possible until we really know what the patient knows. I mean, we don't send our children to school and start them out in 8th grade. We send them to kindergarten for a reason. So we get basic information and then we build on that. And I think we need to remember that when we're doing our patient education, whether it's regarding new chemotherapy or treatment plans or palliative care. We've got to remember to start simple, and maybe we build on that very quickly, or maybe it takes a bit more time. Number one, I actually think it helps with adherence because patients understand what we're asking of them and why we're asking that of them.
Obviously, patients have different learning preferences and learning styles in terms of how they best receive information and retain that information. So as part of these education discussions that we're having with our patients and their caregivers or their family and their support system, when they are diagnosed with metastatic breast cancer, we have to tailor that education to them specifically. So what are some ways that you've experienced or that you have heard of that we can use different types of visual aids or other modalities or tools to enhance that education that we provide?
If people want to know where their tumor is, what does my pancreas look like? What does my pancreas do? What do my axillary lymph nodes look like? And where exactly are those? And what do we mean with a sentinel node? Really, we can find a lot of those images to be helpful. Some people want to see their actual scans. I'm very fortunate because I work in a community practice. We can have branded and non-branded educational material. Pharmaceutical companies, boy, they have really worked hard to come alongside oncology teams and their patients and help with education. And sometimes just on their website for a particular drug or a particular disease state, there's some really beautiful, beautiful educational pieces. ONS, you work for a company that makes wonderful, patient-friendly, provider-friendly, nurse-friendly educational information that helps us have a better way to bring that information to a patient and present that information. I think what's really kind of key to keep in mind is, and you hit on it, patients are going to seek information. And so we need to make sure that we're giving them really good, reliable, durable information, because if we're not giving them good, websites, if we're not giving them good written material, if we're not giving them good verbal information and education, they're going to contact Dr. Google. Dr. Google is good for a lot of things, but sometimes patients can go down a rabbit hole that's not appropriate or not accurate. That's not a good place for them to be.
Absolutely. I think more now than ever, it's important to keep that dialogue open and not necessarily, we know patients will seek information and we want them to. We want to empower them to learn and to be in charge of their own health and make that part of that shared decision making. But we also want them to feel comfortable bringing new information that they are finding to us and for us to establish that trust relationship so that if they bring something to us and we have concerns that this is not based in evidence or we don't, this is not really what we would recommend as part of your treatment plan, whether it's complementary or alternative, being able to have that trusting relationship where we can guide them on what truly could be helpful or for them to avoid things that could potentially be harmful. It's a challenging time, I think, right now in healthcare of, maintaining that trust with our patients and trying to guide them towards truly what is evidence-based and what is our best recommendation for them in terms of their treatment.
I think sometimes patients just assume their medical team is going to poo-poo any alternative therapies, or complementary therapies is really the word I should use. And so sometimes I think they seek those out and we don't even necessarily know that they're using them in combination with what we're doing with standard of care or their current treatment regimen. So we do want to be open. We want to have those open hands, open arms, if you will, in a posture that you can talk to me about whatever is important to you. And I'm not going to scoff at you. I'm not going to scold you. I'm going to help guide you with evidence-based. Regardless, I'm going to accept you and care for you.
Well, let's put some of these sort of concepts into practice. Do you have a short case study of a patient that was diagnosed with metastatic breast cancer? Can you walk us through that patient's experience and maybe what role communication played in that care?
Sure. I'll kind of give you a thumbnail sketch. Let's call her Anita, if you will. Oh, she's in her late 50s and actually got diagnosed with breast cancer, early stage breast cancer in 2019, underwent surgery, chemotherapy, had some radiation, and was then on anti-hormonal therapy. Things were going great. As a caveat, she has polycystic kidney disease. So she follows regularly with her nephrologist. And they did a scan, not because she was symptomatic, not because she was having any problems. It was just their serial scan that they do to monitor her kidneys and the cystic nature of that disease. And lo and behold, she showed up with some abnormal lymph nodes. She showed up with something very unusual near her GE junction, which led to more scans and more scans. And this woman who had been walking along, being very adherent to her endocrine therapy and thought her disease was well in check, now finds herself with metastatic breast cancer. That's not a place she expected to be, for sure. Incidentally, this happened to be about 8 or 9 months before her daughter was getting married. Now, because she has a hormone-driven breast cancer, that, of course, would be standard of care to treat her initially with an endocrine-based therapy. And so she got switched to an endocrine-based therapy along with a CDK4/6 inhibitor. We had to radiate her hip because she had an impending fracture, which she was totally asymptomatic with. Again, just crazy. It's really almost a godsend that she has polycystic kidney disease because that helped us find her metastatic breast cancer. We would have had no reason to scan her. She was totally asymptomatic. So we get her started on this. She's very intelligent, very articulate, and really was part of all of this decision making. But she did kind of lay the ground rules, which I thought were interesting. We scanned her initially 3 months in to make sure she was responding to her first line metastatic therapy, which fortunately she was. So now imagine we're about 5.5, 6 months, right around there, out from the wedding. She put the ground rules down that she did not want any more scanning unless there was an emergent situation until after the wedding. She had very good reasons that she had lined out. That was a reasonable thing. She had demonstrated regression. She was tolerating therapy well. She is very adherent, comes to her appointments regularly. If she has questions, she calls in. And so we felt like, although it made us a bit nervous, we felt like that was a reasonable request because your daughter getting married, that's a pretty big deal. And she really wanted to focus on her daughter. And thankfully, she got scanned right after the wedding, further regression of her disease. So all of that's kind of a happy story, but it was important for her to drive that piece. Now, if she would have shown up with brand new symptoms or a medical issue that we needed to address, of course, we would have scanned her, moved on with further evaluation, and she would have allowed that. But I also think it was important to give her a piece of control back because all that control had been taken from her very, very, very quickly.
That just highlights the importance of knowing your patient, understanding what's important to them, what they place a high value on. And then for this patient's situation, it was that freedom from distraction during that critical pre-wedding period and finding a way to share that decision-making with her so that she can have what she needs and what is important to her, but we can also feel like we are caring for her in the best way possible. So that's a great example of that. So when we think about Anita's case that you just shared with us, can you reflect a little bit about how the discussions took place when her metastatic disease was discovered? What were the discussions around different testing that would be required in this new sort of phase of her care? And specifically, were there discussions about biomarker testing, genetic or genomic testing, and any additional diagnostic testing that would be needed?
Oh, wow. You are talking about Pandora's box right now, aren't you? We can talk specifically about Anita, but I also think as oncology nurses, we need to start really opening our minds and really getting excited about where we are right now in biomarker testing, genomic testing, etc. When we have brand new tumors, whether they're early stage or not, and specifically then speaking of metastatic stage, it's so important that we know that tumor. If we were in the military and we were getting ready to go to war, the most important thing we would need to know is every single detail we could gain and glean about the enemy. And that's how we need to think about those tumors. Anything we can understand about those tumors. So when we do biomarker testing, whether it's on tissue or whether we do liquid tumor biopsies, what we're looking for is we're looking for mutations or weak spots, if you will, in that tumor that's driving that growth and that division of cell, etc. If we find biomarkers that we call actionable, meaning that we find this mutation and we have a drug that blocks that mutation, that is what is going to guide and drive our treatment. Sometimes that can take a bit of time, right? And if we have a patient and they just find out they have metastatic disease, well, they want treatment yesterday. And I understand that. Well, many of them want treatment yesterday. But frequently there is a very important period of waiting and allowing us to learn that enemy better by reviewing genomic testing, looking at that next generation sequencing, looking at any positive biomarkers. In breast cancer, they may have started out ERPR positive. Are they still ERPR positive? Then there's this whole new world that's opened up with HER2. We used to think it was just HER2 positive. Now we know that we have HER2 low, we have HER2 ultra low. So patients that might have been diagnosed 5 years ago now, and we call them HER2 negative. Now we're pulling these tumors back out, looking at them again, making sure to understand, is there any staining in those membranes? Because any of those can open up other treatment options. That can be very concerning to a patient when we say, okay, we're going to draw blood, or we're going to take another piece of this lymph node that's easy to grab to see if we can really gather more information. Hang tight, we'll talk to you in, 10 to 14 days. That can be alarming to a patient. But yet that information that we can get in that period of time gives us so much ammunition on how to treat that tumor. So again, education. I don't say this because I'm talking to you and you're a representative of ONS, but ONS really has a beautiful piece, an educational tool on biomarkers. I have a story about a biomarker. I have a patient. Now, she doesn't have metastatic breast cancer. What she has is metastatic lung cancer, which is kind of the poster child for biomarkers right now. She was diagnosed and had to wait a period of time. And that was very, very difficult to her. She really desperately wanted us to start some IV chemo, but she had really kind of minimal tumor burden and she was asymptomatic. She just had these lymph nodes is what took her to the doctor, quite frankly. And so we walked with her during that waiting period. She had an actionable mutation of her tumor, a rare one, a very rare one, got started on medication because there was a drug on the market for this mutation. And and this sounds miraculous, but this is how important understanding biomarkers are. Within 6 doses of starting that drug, her lymph nodes were gone. 6 doses. That's how important understanding biomarkers are, because that's a weakness in the enemy that we can aim at. So helping patients understand that. We want them to understand that their sense of urgency is also our sense of urgency, but we need these pieces of information. And sometimes those pieces of information take days to sometimes a week plus to be known.
Absolutely. And I think you mentioned this for the patient. If they're diagnosed with metastatic disease from initial presentation, that's sort of a different conversation. But for those that did progress and became metastatic following initial treatment, that discussion also has to include why we're testing again. Maybe we tested the first time and we have to sometimes test again to make sure that that disease that we knew originally hasn't itself changed and potentially would have different targets at this point. So that's part of that discussion too, depending on how and when the patient's cancer becomes metastatic. I think that also shapes that conversation like you just shared.
And you know what? I don't want to make myself sound like a dinosaur, but for our newer oncology nurses that might be listening to this podcast, this wasn't an option for us 15 years ago. It really wasn't. This is such an exciting time to be in oncology, and such a time filled with hope for our patients as well.
So let's talk a little bit about goals of care. When a patient, again, whether it's at presentation or a eventual progression of disease, when disease becomes metastatic, that certainly emphasizes the great importance of ensuring we know the patient's goal of care and we share clearly with what our expectation and intention of the treatment we're providing. What is the goal of that treatment? So how do those conversations evolve when we're discussing goals of care, patient preferences about treatment options, and just long-term planning for what treatment could hold, including, eventually maybe clinical trials?
I think when we're talking about goals of care, first of all, we need to make sure that the patient understands, when we're talking about metastatic disease today, June 2025, this is not a disease that we can cure, but hopefully it's a disease that we can manage for years to come. With that in mind, what's important to that patient? What is important to that patient in terms of life goals? what's important to that patient in terms of toxicities that they will allow and toxicities that they won't allow. I had a patient one time that is a horse surgeon. Now, I just happen to know you live in the Midwest like I do.
Yes.
And so you understand that's important in the Midwest.
I had no idea that career field existed, but why not?
Why not? Someone has to operate on horses, right? And he made it very clear that that was important to him. And he wanted to be able to do that for as long as possible. Keep in mind that the drug regimen we wanted to use on him involved 2 drugs that could cause peripheral neuropathy. If I'm going in for surgery, I don't want my surgeon to have peripheral neuropathy and drop something in me.
Sure, the horses don't either. So that's very important.
That really helped drive his treatment. And we need to listen to those folks with what's important to them, because we are in a time where the patient may have options. They may be, I don't want to say choose, but they may be able to look at option A and those potential toxicities. They also may be able to look at option B or C and help really guide their care team to what would work best in their lifestyle and their goals. And I'm so glad that you brought up clinical trials. I work with 2 oncologists that they're on their team. I don't work with the research team per se. We have a research team and we have 2 medical oncologists, and their aim is to help guide and direct patients that are interested in clinical trials. At our particular office, we're very blessed, we're fortunate, and we have phase 1 all the way up to phase 3 trials. That gives patients an option as well. And, we also sometimes kind of poo-poo phase 1s. We're like, oh, well, those are dose finding and those rarely help a patient. I have a patient that actually responded to a phase 1 for about 14 months. There's a lot of hope and a lot of excitement in clinical trials now. And I think patients are more open-minded to them. I remember years ago when I started practice, she'd bring up the idea of clinical trials. And more than one time I would hear patients say, I don't want to be a guinea pig. Now I just feel like we're in a very different time period. We actually have patients that come to us and say, are there clinical trials available for my disease?
Let's talk a little bit about, we already touched on the notion of the next generation sequencing or that genomic testing that really helps us identify those biomarkers and associated targeted therapies that go with that. Most of those therapies are oral therapies. And so patients with metastatic disease are essentially giving themselves the treatment when they are at home. So can you share some examples or some wisdom about just strategies to help patients remain adherent to their treatment? And if they're having adverse events, how do we optimize that at-home monitoring for them, knowing that so many patients with metastatic breast cancer will eventually have an oral therapy that they will then take that responsibility for dosing at home?
Well, now that's a loaded question. Oral therapies, wow, that really allows the patient a lot of freedom, which is a wonderful thing. However, that really allows the patient a lot of freedom. And what I mean by that is when I was an infusion nurse, I knew that the drug I gave was the right drug, the right route, the right dose, the right patient, all those 5 R's that we had, drilled in our head and understood the importance. When we ask patients to take medications at home, we don't always have that knowledge and that assurance that they're taking it the right way. When we study adherence, what we understand is that one of the most common reasons why patients aren't adherent is because of lack of education and lack of understanding. And I don't mean their lack of education. They don't have a PhD, so they clearly can't be adherent. That's not what I mean. I mean, they don't understand the regimen. They don't understand the importance of it. And, you think about it. If you don't have a lot of medical knowledge, taking a pill seems less important than getting an IV. It seems like a bigger deal if I would miss getting my IV therapy. Oh, whoops, I forgot to take a pill. Maybe it's not such a big, important piece of my treatment. So education, when we set that patient down, helping them understand how this drug works, mechanism of action in a simple term, why it's important to take it as scheduled, why it's important to take it with food or without food, why it's important to take it consistently. And then that education doesn't stop there. Education is ongoing each time we see that patient. So in the last month, how many times have you missed taking your drug? Okay, you've missed it 3 times. So again, being open and not scolding the patient. On those times that you missed that medication, what happened? Did the alarm not go off? Did you forget to take the medication with you wherever you were going? What exactly did that look like? So we can help set those patients up for success. That's what we want them to do. We want them to succeed with these oral medications. So do patients do best with journaling? I have several patients that love to keep like a little piece of paper by their pill bottle and they'll write, June 11th, 10 a.m., took this pill. That's how they like to do it. I have other patients that actually have paper calendars and like to make an X. Other people are very tech savvy. They want alarms to go off on their phone, or they want, those types of check systems. All of that is really important. And then understanding, being aware of potential toxicities and having management techniques. So for example, let's just say potentially the medication could cause nausea. We need to make sure they have an antiemetic at home and they're prepared to take it at the right time and they understand how to take it. Because if we don't manage a patient's toxicities, I promise you they're going to manage their toxicities. And sometimes that's just holding their drug. I learned this from a patient of mine, very, very sweet lady. And we started her on an oral medication that has a high risk of causing diarrhea, manageable diarrhea, but can cause diarrhea. Every single time she would come in, I would say to her, Karen, do you have any diarrhea? No, none. Okay. We do this month after month. And finally, by about month 4, I said to her, I am so surprised. Almost everyone I've had on this particular medication has had a bit of diarrhea. We've been able to manage it, but they've had a bit of diarrhea. And she said, oh, Kristi, I have diarrhea, but whenever I have it, I just stop the pill for a few days and I restarted.
Oh, man.
She was managing her toxicities. She was managing her. So, and we all have stories like that, right?
Mm-hmm. Mm-hmm.
We have to make sure patients know, hey, you may have this. We can manage it. Let me know. I understand there's a wonderful, wonderful new trend of having oral medication navigators. We're not fortunate enough at our particular clinic to have one of those yet, but I do hear that those wonderful beings exist and have caused magic in the clinics in which they work, setting up call schedules and such. And I've also heard where other offices will do that, set up call schedules to check in with patients. We started you on this medication. How you doing? Has the rash started yet? Are you having any perinicular issues? All those kinds of things.
Absolutely. As you just mentioned, that proactive assessment for patients, knowing that they won't be coming in to see us as regularly as they would if we were administering an infusion therapy, creating a proactive schedule to check in with them, even if it's not an official visit in the clinic, just to get ahead of those adverse events that we know are likely to occur. And then, as you mentioned, making sure that they understand what is worth a call to us. Even if we expect something, we still might want to know about it. So what are those thresholds for communicating with us, letting us know how you're doing, and also just normalizing that, as you said early on, sometimes you might miss a dose. We're not here to judge you or to shame you about that. Life happens. And so normalizing that, hey, it might happen, but we want to know about it. We want to understand what challenges you're experiencing. So if there are things that we can do to help remove those issues for you or help you kind of accommodate to them, we can't help if we don't know. And so opening those communication channels is really important for our patients that are taking these oral therapies for their metastatic breast cancer, just showing that we're open to supporting them in the way that fits what they need.
And I think we have to remember, rarely is that the only oral medication they're taking. I am helping two elderly parents, and we have implemented pill boxes. And I have to tell you, I'm a nurse practitioner and I'm not sure I could keep their medication straight. I say all that kind of tongue in cheek, but think about our patients. Many of them have hypertension. Many of them may have thyroid issues. They may have, they may be diabetic, on and on and on and on. And here's one more pill to fit in the mix. And you take these with foods, you take these without food, that's a lot for patients to manage at home. And some of our patients aren't fortunate enough to have support systems. And so we need to keep all that in mind too.
So Kristi, are there any helpful supportive resources or websites that you would recommend specifically about metastatic breast cancer that we could share with patients, families, or their caregivers?
There are a lot of good, reliable websites out there. I always direct people to National Cancer Institute. I direct people to American Cancer Society. I direct people to, there's a really nice one called Metaviver. I actually know the patient that started that. She was a very, very young diagnosed breast cancer, had metastatic disease at the outset, had young children at the time, and she's been in remission for several years and really has a beautiful website that I guide people to. And as I kind of alluded to earlier, if they're on specific drugs, many, many, many times the particular pharmaceutical company will have a patient-friendly version. Now, I look at it first before I guide people there. But many times, pharmaceutical folks can be our friends, and we need to remember that. And many of them have just lovely sites to look at.
Absolutely. And we'll be sure to include some of those links in the episode notes for our episode today. Well, Kristi, we're about at the end of our episode today. It's been a delight talking with you and just sharing our experiences and hearing some of your examples of how you've cared for patients with metastatic breast cancer and have those difficult conversations that challenging but necessary. And we as nurses are certainly in the best position to help support those discussions as they continue over the span of a patient's care. Do you have any thoughts about how healthcare professionals should evaluate maybe implicit or hidden biases that they bring when they are caring for a patient with metastatic breast cancer?
We all probably think we don't have biases, but research says that we certainly all do have some. I think the important thing to remember is we're not walking in their shoes. We don't know what all they're bringing along with them in this journey. We need to be open, accepting, no judgment. We need to offer the best medical information that we can, evidence-based. We need to make sure that they do understand it, that we've done due diligence in our education. And then we need to make sure they understand we're here to walk that journey with them, regardless of paths that they choose, regardless of medical choices they may make. I think that's important. I try to stress that to patients. I just had a patient that is in complete remission of her metastatic disease and has decided to go off conventional therapy and is going to go on a different route. And I stressed to her, we're still here for you. We're still your oncology team. We won't leave you in that decision. And I think that's really, really important.
What are some common misconceptions about metastatic breast cancer, do you think?
That it's the end of the story. And Jaime, it's not. I wish that I could open up the clinic in which I work and show you several patients with metastatic breast cancer. Metastatic breast cancer in 2025 is not what it used to be. I have so many folks in my practice that are on treatment for their metastatic disease and have been for several years, are living life to its fullest. I have a dear, dear, dear friend who was diagnosed with a metastatic disease at the outset. And that was about 5 years ago. When she started this journey, she had 4 young adult sons. Fast forward 5 years, she continues to work. She still has those 4 adult aged sons, but now she has 2 daughter-in-laws and 2 grandchildren. That's what metastatic breast cancer looks like now. Many, many patients can live an extended period of time. And sometimes I think we forget to cheer for stable disease. Stable disease is great. I tell patients, I know that this is maybe kind of corny, but I love to tell them they can live with weeds in their garden. They just can't let the weeds take over their garden. We have to remember that. And today we don't have a cure, but you know as well as I do, we live in a rapidly changing time in oncology. What's going to be out in a year? I don't know. And I don't think you know either. And so there's just so much hope right now that we can offer patients. We have 2 or 3 doctors that have med students with them all the time, and they are forever bringing med students in to see particular patients and saying, that patient right there has metastatic disease. That's what metastatic disease looks like now. I think that's helpful to these med students because it's not the end of the story.
What additional training or education do you think oncology nurses need to help stay current about metastatic breast cancer?
I think we need to always be looking for the next best thing we can learn. There are so many beautiful sources on the internet that we can do continuing education programs to keep up to date. ONS has many things that we can do online. Also going to conferences, local conferences, regional, going to national ONS, for example, that was held recently, in Denver, but understanding the need. This is an ever evolving environment, and we need to be ever evolving as well. I always say that you cannot be complacent and work in oncology because how we treat patients today is not going to be how we treat patients tomorrow. There's always a local dinner program to go to that we can improve upon, etc.
Of course, joining ONS or attending your local chapter events is a great way to stay connected, not only to what's new in the science, but also creating community with your fellow colleagues in oncology nursing is a great way to do both at one time.
Oh, absolutely.
Well, Kristi, thank you so much for all the time you spent with us today talking through this challenging but important topic of having these difficult conversations with patients who are living with metastatic breast cancer and sharing some of your experiences and tips for having those conversations with patients. Do you have any final comments to share with our listeners today?
If they can take one pearl home today, I just want them to take home the pearl of hope that we have to offer patients now. And also just remembering our patients are walking a tough road, and we're here to love them, to care for them, to show them compassion and acceptance and walk that journey with them. And it's an honor for us.
Well, thank you again, Kristi, so much for your time today.
Thank you, Jaime.
Thank you for listening to the ONS Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.